Good evening, and welcome again to our series, Demystifying COVID-19, the Science of SARS-CoV-2. My name is Susan Van Epps, and I work for Loudoun County Public Library. Tonight's program is the second in a three-part series co-hosted between the library and the Hhmi Janelia Research Campus. On behalf of the library, I just want to say a quick thanks again to the entire Janelia team for their partnership and their efforts organizing this very important series. And now it's my pleasure to introduce to you Dr. Ron Vale, Hhmi Vice President and Executive Director of Janelia Research Campus in Ashburn, Virginia. Good evening, Ron.
Great, thank you, Susan, and great to work with you on this series and the Loudoun County Public Library. So I'm the Executive Director of Janelia Research Campus. We're a life science research institute in Ashburn, Virginia. And normally we host this series called Dialogues, where we invite Loudoun County to come to our campus and hear a public lecture. And now, due to COVID-19, we're continuing this series online. And I would now like to introduce Janine Stevens, who will tell us a little bit about Dialogues. Janine.
Thank you, Ron. Hi, everyone. I just want to let you know that tonight's talk will be a little bit shorter than last week in order to allow for even more time for audience questions at the end. At the bottom of your screen, you should see a raise hand button and a Q&A button, and you can use either one of these to ask your question. And if you raise your hand, we will call on you, and if you write a question in the Q&A box, we will also hopefully call on you if there's time. Alternatively, you can submit your questions anonymously and we will ask them. So again, keep in mind that this is our second talk in a three-part series that is covering everything from the basic biology and immunology of the SARS-CoV-2 virus to how it spreads and efforts to treat and prevent it. So if you don't get all of your questions answered tonight, you will have another opportunity next week. And now I am going to turn it over to my co-host and co-organizer of the series, Sarada Viswanathan.
Thank you, Janine. Thanks, Susan and Ron, for the introduction. And thank you all for joining us this evening as we host the second talk in this three-part lecture series. We are extremely delighted to welcome back Dr. Angela Rasmussen today. Dr. Rasmussen is an associate research scientist at Columbia University's Mailman School of Public Health. She holds a PhD in microbiology from Columbia University and has previously conducted research at the University of Washington. She is also a member of the World Health Organization's ad hoc expert group on preclinical models of COVID-19 disease. A brief introduction to her work. Dr. Rasmussen is a virologist specializing in host response to infection. She studies viruses that are highly pathogenic and pose a major threat to global public health, like Ebola, dengue, avian influenza, and has carried extensive research on the SARS family of viruses. And now she exclusively focuses on SARS-CoV-2. Dr. Rasmussen, in this three-part series, will talk to us about the basics of COVID-19 pandemic, including what is known, what is not, and what the scientific community is trying hard to discover. So last week, we talked about some basic concepts of virology and immunology, and this week, she'll discuss how the virus spreads through the population and talk about the risk reduction strategies that we can all adopt and protect ourselves. Should be very timely. So Dr. Rasmussen, on behalf of the audience and all of us here, a huge thank you for your contribution to science, and a big thank you also for taking time and talking to us and communicating your research with the community. We really appreciate it. So thank you and welcome.
Well, thank you so much for having me back. I will just jump right into it. And as Janine mentioned a few moments ago, tonight, my talk is going to be a little bit shorter so that we have time to get to so many of the great questions that the audience asked last week. Hopefully this will be informative and useful. This week is going to be a lot more probably applicable to people's daily lives. And I know this has been a really hot topic both in the media and on social media lately. So as mentioned, I'm going to discuss epidemiology and transmission today. Of course, I'm going to begin by giving my equity statement and territorial acknowledgement. And today I'm in New York, so I'm presenting from the unceded ancestral homelands of the Lenape people. And I acknowledge and honor the first people of this territory and their tribal governments, their histories and ancestry, and their roles today in caring for these lands. And I'd also like to acknowledge the long history of systemic inequity in academic science that has spanned decades. Columbia University, the institution that I work for, was founded using profits from the transatlantic slave trade, and for nearly 2 centuries excluded women and people of color from its academic community. This has left a long and painful legacy of racial and gender-based inequality, and that continues to this day, unfortunately, throughout academia. And I just encourage everybody watching this presentation, participating in this wonderful opportunity to meet with you, to just consider how you can contribute to making all of our communities and our country a more equitable place to be. And without further ado, as I mentioned, tonight I'm going to be talking about epidemiology and transmission. And epidemiology is the study of epidemics, or it's the study of how viruses, in this case, but more broadly, how diseases spread within a population. And this is just a graph from the New York Times showing back in, I think, May or April, how COVID-19 was spreading in the United States, places where there was high transmission. Obviously, this graph now probably looks a lot different because more and more of the country is red compared to what it looked like back then. And part of the reason for virus spread, or one of the measures that epidemiologists like to use, which you may have heard about, it's gotten a lot of attention since the very beginning of the outbreak, is the number that we call R naught, or the viral's reproduction number, the virus's reproduction number. So R naught basically refers to how many people an infected person will infect, will go on to infect. So here's a couple examples of different viruses with their different R naughts. Hepatitis C and Ebola are both R naught 2. That means every person on average who is infected will infect 2 other people. HIV will infect 4 other people. Same with SARS Classic. Mumps is more contagious. 1 infected person will infect 10 people. Measles is one of the most contagious viruses of all. The R naught of measles can range very dependent on the amount of immunization in a population. So in most communities in the United States now, at least prior to vaccine hesitancy, the R naught for measles was obviously much lower because most people have immunity. We had achieved herd immunity until people stopped getting their measles vaccines. And now in some places that R naught would likely be higher because there are more susceptible people in the population. So R naught is not a static number. I think a lot of people early on during this pandemic were looking at R naught, seeing anywhere from 2 to 5, and thinking that that's really a forecast of things to come. And it's not. R naught just reflects an average of the number of total infections that there have been. You back calculate that to figure out how many people were infected and how many people they infected. So R naught can change, and that's really important to understanding control measures, because one of the control measures that people try to achieve, or the measures of how well those control measures are working, is to see if R naught is getting below 1. So if most people on average, I'm sorry, I have a tickle in my throat. Most people who are getting infected infect fewer than 1 person, which is no people, then R naught is below 1 population wide, and the virus is just not spreading as much in the community. However, R naught, as I mentioned, is an average. So it's not always the best way to look at this, because it can really describe a number of different scenarios. And this is a figure that a friend and colleague, Maya Majumdar at Harvard and Boston Children's, made to show some of these different scenarios. So in scenario 1, you have 4 cases of infected people, and each of them infects 2 other people. So that's R naught 2. But in the second scenario, this is still R naught 2. You have 4 infected people. 3 of them don't infect anybody else, and 1 of them infects 8 other people. So that's what we would call an over-dispersed R naught, which I'm going to talk about in a moment. And scenario 3 here also shows a dispersed R naught. This is where you have 1 person, you have 4 infected people, just like in the other scenarios. one person infects 4 people, one person infects 2 people, and the other 2 people infect 1 person each. Again, the average overall is that the R naught is 2, but this is really describing several very different situations, and that's what I'm about to talk about next. So maybe we should consider dispersion instead. Now, if you recall, on this slide, I described these 2 scenarios as dispersed R naughts. Dispersion refers to a situation in which one person infects a lot of people and some people don't infect anybody at all. So here's a low dispersion. This is an example of low dispersion. You have one primary infection. They each infect, that person infects 2 people. They each go on to infect 4 people. One of them goes on to infect 1 person. One goes on to infect no people. Some infect 4, 3 people. One infects 7. So it's different for every situation, but in this one, everybody kind of goes off and infects 1 or more people for the most part. In this scenario, however, this is a high dispersion, which is looked at a variable called K. You're not going to be tested on K. I'm not even going to talk about how K is calculated, but basically low dispersion, K is greater than 1, high dispersion, K is less than 1. And in this situation, you have one person who infects 16 different people. Most of these people go on to infect nobody else, or they infect 1 or 2 people, and one of them goes on to infect 11 other people. This is what we call a high dispersion event, because most of the time infection doesn't result in a secondary infection, but when a secondary infection occurs, a lot of people are infected. And that is important because that seems to be how SARS coronavirus 2 is actually spreading. It may be R naught 2 or 3, but that's not because every person who gets infected is going on to infect 2 or 3 other people. A few people who are infected are going on to infect a lot of people in what we call a super spreader event, which I'll talk about in a moment. But first, I'd like to recommend this great article about dispersion that just came out yesterday by Zeynep Tufekci, who is a sociologist and just a really great thinker. She's at the University of North Carolina in Chapel Hill. And this piece in The Atlantic, extremely timely, as I mentioned, came out yesterday, really does a fantastic job of explaining why R naught is really maybe not the best measure for looking at how this virus spreads, but maybe we should be thinking about dispersion, because as I'm about to show you, the super spreader events that are driving most of the transmission for this virus are specific situations that we need to think about preventing in terms of allowing them to occur. Maybe we don't need to make such across the board reduction measures. Maybe we need to make sure that these conditions are not right for super spreader events to happen. So what are super spreader events? Well, these are events in which 1 or 2 or a small group of infected people result in potentially hundreds of other new cases. And that's just 1 person. And here are some famous situations. So the Shincheonji religious group in South Korea was having very large religious services. 1 infected woman resulted in over 500 new cases of SARS coronavirus 2. So this was obviously a major super spreader event. And this was when we started to understand that maybe these super spreader events are more common than we realize. Maybe it's not just sort of everyday household transmission that's driving this pandemic. Maybe it is large events like this. There are office buildings, office settings in which super spreader events have occurred. One in particular was written up in Emerging Infectious Diseases, which is a journal published by the CDC that described an open office call center in South Korea in which 40 people, roughly 40 people on the same floor were infected, probably by 1 or 2 people who came into the office while they were infected. They didn't know they were sick, most likely. This virus spreads pre-symptomatically, so before you develop any symptoms at all, you are most infectious. They came to work, they were sitting at their cubicles and talking all day into the phone, and people on the same floor, in the same room got infected, but not people in a different room and not people on other floors of the building, suggesting that the super spreader event was within this enclosed space. So again, that gave us a clue to how this virus is being transmitted. The Skagit Valley Chorale had a practice. That's in Washington State, about an hour and a half north of Seattle. This choir got together for practice for a few hours. They were physically distanced during the practice. They tried to be very conscientious about touching each other, about having close physical contact. And yet the vast majority of people who attended this choir practice actually became infected. Famously, at the University of North Carolina, they reopened in August for in-person classes, and there were immediately outbreaks in several of the student housing buildings. Again, this looks like it was a super spreader event, probably caused by a handful of infected students that ended up in a number of new cases. Ultimately, it resulted in the school rapidly going back to online-only classes. Memorial Day, many people may recall that on social media, there were a lot of pictures going around of this large party at the Lake of the Ozarks for Memorial Day. Now, this was outdoors, so I think a lot of people thought, well, it's not a big deal because it's outside, it's sunny. But there were a number of cases associated with this, and only 1 or 2 people were identified as being infected when this started. So this was a super spreader event, again, in which just a handful of people resulted in a large number of infections. There have been numerous other reports of super spreader events occurring from people who are attending large parties or going to bars or nightclubs and being in similar environments. And then most of us have also heard about the Diamond Princess cruise ship, in which the passengers' vacation went very wrong and they ended up stuck on the boat quarantining. It started off with a handful of cases, and ultimately there were over 700 cases on the entire ship. And now this was a longer term super spreader event because people probably weren't all gathering in the same place at once. They were relatively confined to their cabins, although there were opportunities for them to get together to get food and things like that. So this was also over a longer period of time, but it really also was a super spreader event in which a couple of people ended up resulting in the infection of many. And then there was a restaurant in Guangzhou, China. This was actually not a huge super spreader event in terms of hundreds of people getting infected, but it was one infected pre-symptomatic person who was sitting upwind from several other people in the direct path of an air conditioner. And multiple people downwind from this person ended up getting infected, probably because they were in the direct flow of the air current from that air conditioner. And this was a poorly ventilated space that was very crowded because it was right around the Chinese New Year. So restaurants are also a place where super spreader events have happened. And it's thought that some of the spread in some of the Sunbelt states over the summer was largely driven by restaurants and bars and things like that, which are, again, opportunities for super spread because there's a lot of people who are all susceptible all in the same place. And then finally, athletic facilities. So gyms, professional sports athletic facilities and college athletic facilities have also proven to be spots for super spread. The Clemson football team, among many other college football teams, as well as now at least one professional football team, several Major League Baseball teams have all had outbreaks that probably have resulted from 1 or 2 infected players being present in a locker room or gym or other athletic facility. So these are all good environments for super spreader events to happen. And we think now that because of the dispersion of the way that this virus spreads, the pandemic is largely driven by these super spreader events. So as I mentioned, it's not impossible for somebody to get infected at a super spreader event and then go off and infect 1 or 2 people. They may infect 0 people. A lot of it is really going to be dependent on behavior, timing, conditions where they are, and the people around them and their susceptibility. But we do know now that super spreader events are very important in terms of the epidemiology of this virus. So we really should start thinking about how to prevent these as part of our strategy to reduce community transmission. So as I mentioned, the Skagit Valley Chorale was a pretty famous story. When it came out, this also suggested to people that maybe this isn't only transmitted by direct contact. Because as I mentioned, after choir practice where there was one symptomatic person, and that person was very mildly symptomatic. This happened in March, and we definitely knew that COVID was spreading in Washington State. Seattle was one of the first hotspots, and in fact, it wasn't really Seattle so much as Snohomish County, which is directly south of Skagit County, where this occurred, that there was a fair amount of spread at this time in that area. So they were trying to be very careful, but they were taking precautions, assuming that the virus was transmitted by direct contact. So they applied physical distancing. They did not wear masks, but they were very conscious about trying to avoid direct contact. They weren't touching each other. They were staying 1 meter apart, which is probably not enough. But they were in a group. They were in a confined space. And they were singing. Singing will come into the picture in a moment, because when you sing or shout or vocalize loudly or frequently, you're producing more of these respiratory droplets that can carry the virus and infect other people. So as a result, there were 32 confirmed cases, a number, the majority of people who were at this practice. Some people didn't get tested, so we don't know if they got infected. And a number of people died. They were high risk. There were a number of older folks in this choir, and it ended up being a really sad situation and a pretty eye-opening experience, since this group again was taking precautions to avoid transmission, and it still became a super spreader event. So this is when we started to realize, hey, this virus is spreading pretty easily if the conditions are right. So what are those conditions? So this is really a series of unfortunate events that can lead to a super spreader event. Now, we know that people are shedding the most virus during this, what I call a sweet spot. And this paper came out several months ago that showed that people were shedding the most virus at the time of symptom onset, which suggests that, since we know again that pre-symptomatic spread can occur and probably is driving a lot of the transmission of this epidemic, it's really hard to get people to isolate themselves if they don't know that they're sick. People aren't going to quarantine if they don't know that they've been exposed, if they were infected by another person who was pre-symptomatic. So there's this spot early on after symptom onset when symptoms may be mild and difficult to identify, especially early on. Now we know that COVID has a lot of different symptoms. It can be everything from a fever to a headache to a cough to a dry cough to the loss of sense of taste and smell to diarrhea. So that's a pretty vague collection of symptoms. People might not always realize they're symptomatic until after they've already been symptomatic, and people are probably shedding a lot of virus before they become symptomatic at all. So there's this sweet spot for transmission in which people who may not realize that they are sick are shedding a lot of virus. So if one of those people goes to a restaurant, to a choir practice, to the gym, to any of these circumstances, they are timing it just right so that they could potentially spread it to a lot of people. Now, if they do something like that where they engage in behavior that makes it more likely that they're going to spread the virus, so if they're taking reduced precautions, if they're in a restaurant, they can't wear a mask. If they are at choir practice and they can't wear a mask, and on top of that, they're singing. If they are at a nightclub where they're potentially drinking alcohol, potentially dancing with people, breathing heavily, talking to people, trying to talk loudly over music, all of those things are reducing the precautions that you would take in other conditions and other circumstances, like say at the grocery store, and really engaging in behavior that will make it more likely for somebody who is already shedding a lot of virus to be able to transmit it to others. If you're having increased contact with others, again, here I've shown the Peanuts gang, and I thought Pigpen was the one who's infected here and pre-symptomatic and just sort of obliviously shedding virus into the environment. There's people dancing around. There's people having close contact with others. They're dancing, so they're breathing more heavily. This is behavior that can lead to potentially a super spreading event. And finally, the conditions. If it's really crowded, if it's poorly ventilated, if there are not very many people wearing masks, all of those conditions can further lead to more transmission. And if you have one person who just happens to be shedding bucket loads of virus, that creates an opportunity for the virus to infect a large number of people rather than just 1 or 2 people in the household. And it does appear that there are a number of these super spreader events happening to the point where it's starting to look like this virus, this pandemic, may largely be in fact driven by these types of super spreader events. We also have we have an understanding that this has happened with other beta coronaviruses. So there were several super spreader events that happened with SARS Classic in an apartment building in Hong Kong, which I'll talk about in a little bit when we get into modes of transmission. With MERS coronavirus, there have been several hospital-based super spreader event outbreaks. And now with SARS coronavirus 2, we're getting increasing reports of these occurring. So we need to start thinking in terms of reducing our transmission risk, not just about individual things that we should do to protect ourselves from transmission, but also we should start thinking about these circumstances that can lead to these super spreader events. So how does transmission occur? Now, this has been an unnecessarily, I think, controversial topic because for me, it's really common sense. This is a respiratory virus. It's thought to primarily enter and infect the respiratory tract, even though it eventually can affect other organ systems. So if it's a respiratory virus, that's pretty simple. It means that we get it from inhaling or coming into contact with the respiratory secretions of somebody who's infected. So a lot of people have been arguing about what's airborne, what's droplets, what's aerosols. And you know, these terms, there are discipline-specific definitions for them. They're very different. So if a virologist starts talking about droplets versus aerosols, they're usually talking about particle size, and potentially they might be talking about particle behavior, their physical behavior in the environment. They're also thinking about how much virus is in those particles. So they don't care as much about the particles as about how much virus you're going to get from one of those particles and the likelihood that those particles are going to be inhaled or that you're going to come into contact with them. If you ask an infection prevention specialist, they're going to think about PPE and what kind of PPE healthcare workers should be wearing to protect themselves. Is a surgical mask okay, or is an N95 required, or is some other type of respirator required? So these terms can be very misleading, but generally, aerosols are the smaller floaty particles, and droplets are larger particles that may be propelled with ballistic force. So the big globs of spit that come out when you cough or sneeze, as opposed to the little particles that come out when you breathe. And I just think about this as, you know, when I go outside on a cold day and I see my breath in front of me, those are the respiratory particles that you could potentially inhale. So does it really matter if it's a droplet or an aerosol? Not really, if you think about the way that it's going to be transmitted. So you're either going to breathe it in, or it's going to get on somebody's hand, or you're going to touch it and then you're going to touch your face and the virus is going to get into your nose. So these are thought to be the two primary modes of transmission for this virus. We still don't know which is the dominant one. We don't know if for some people there may be one that's dominant over the other. And for example, there are some people who produce more saliva when they speak. Those people can emit more particles when they speak. Or breathe, or if somebody, you know, is working out, they might be producing more particles than they would otherwise. So there could be a lot of factors that go into this, and we could get way far into the weeds about what the definition is of all these different things. But the main thing to remember when you're trying to think about risk reduction and reducing transmission is that this is a respiratory virus. If it gets to your nose, whether by breathing it in or by contact, close contact, meaning indirect contact, where you're standing and talking in close range with somebody, where you could get it either physically from their particles, the respiratory particles getting on your body and then you touching your nose, or from breathing them indirectly. That's how this virus is predominantly transmitted. Same with influenza, same with rhinovirus, same with all of these respiratory viruses that we're more familiar with. So we can take precautions to prevent these, and these are the ones that we should be thinking about the most. Now, there are several other potential modes of transmission. One is fomites. fomites are contaminated surfaces. So if, let's say I have SARS coronavirus 2 and I wipe my nose with my hand, which I shouldn't do because that's gross. But let's say that I do that and then I touch this table, and then my husband comes and sits down at this desk after me and touches the table where I did and then touches his nose. That would be an example of fomite transmission. Or if, let's say, I wipe my nose with my hand and I grab a doorknob at my local grocery store or post office. And then the person who comes after me grabs the same doorknob and then touches their nose. That's another example of fomite transmission. Fomite transmission probably occurs, but it's thought that it doesn't occur as much. People have been more conscious during this pandemic about disinfecting surfaces. And in fact, much of the guidance has focused on surface disinfection, probably too much. So fomite transmission is not thought to be as major of a pathway, but it is something people should not forget about. It can happen. Another route of transmission is ocular. We know that the eyes can express ACE2, which is the receptor for the virus, so they're probably susceptible. We also know that these lacrimal, the nasolacrimal glands and this passage basically between the eyes and the nose also has epithelial cells that are expressing ACE2. So cells there are probably susceptible to viral infection. What we don't really know is the percentage of people who get SARS coronavirus 2 via the eye. The eye is a special site as far as your immune system is concerned, and so it does have sort of beefed up antiviral defenses. So we don't really know how much of a risk that is, but it's still enough of a risk that you might consider wearing eye protection. There have been several studies that showed that in China at the time of peak transmission in Wuhan, people who wore eyeglasses were less likely to get coronavirus infection. But again, that's only some evidence that's really indirect. It doesn't necessarily prove that you are protected by glasses or that eye protection offers help at the community level. So it's just something to think about and be aware of, but know that it can probably occur. So you should be thoughtful about that. And then finally, we know that people who are really sick have virus, including infectious virus, in their feces. As I promised before, there was one case in Hong Kong during the original SARS outbreak in 2003 in which a number of people were infected in the Amoy Gardens apartment building, and it was traced back to a faulty sewage line. And it was thought that when you flush the toilet plume that normally rises out of the toilet, this is a cloud of aerosols basically that is formed whenever you flush a toilet, that had some fecal matter in it, and that contained SARS coronavirus, and people were infected via toilet plume generated fecal bioaerosols. What we don't know is if that really occurred. It was very difficult to explain that outbreak, and when they found that there was this problem with the sewage system, they assumed that's the hypothesis, but it hasn't ever really been conclusively proven. There have been several reports that this type of fecal bioaerosol transmission may have occurred as well with SARS coronavirus 2, but again, it's pretty circumstantial evidence. So for right now, that's kind of a question mark. We don't know for sure if it's transmitted this way or if it can be frequently transmitted this way. But one way around this is to just avoid using public restrooms that don't have lids. And when you're using your restroom at home, to close the lid on the toilet. That's pretty much all you need to do to reduce your risk substantially of fecal transmission. I should add, there's no epidemiological evidence that fecal transmission is something that happens. And if it were something that happened a lot, we would be seeing a lot more household transmission of this virus. So again, it is a mode of transmission, but the main modes that we need to be aware of are inhalation and contact transmission. So my last slide here before I'm going to break for questions is just that risk reduction is additive. So a lot of times people have focused in this pandemic on you should wear a mask and only wear a mask, or you should make sure you physically distance, make sure it's magical number of 6 feet. But 6 feet is not a magical number in certain circumstances. We know that in enclosed spaces, these aerosols, these respiratory particles that we're producing all the time can build up. And eventually you can inhale enough of them that you might become infected. So I try to recommend to people that they should do as many risk reduction measures as possible. And this is really not that hard to do. It's not giving you a big giant to-do list. This is really just common sense ways to reduce your risk of being in a possible super spreader event. So avoid crowds. If you're not around a crowd of people, you can't be part of a super spreader event that's occurring within that crowd. Avoid enclosed spaces if possible. As I mentioned, enclosed spaces do not allow, they allow these aerosol particles to build up, and you could be at increased risk for exposure. Avoid close contact with somebody for long durations, even indirect contact. So if you're sitting, you're close proximity to a person, you're talking to them for a long time, maybe don't do that, or maybe have the conversation outside. Maybe make sure you're wearing a mask and that you're distanced and that you're outside, even better. But try to implement as many of these things as possible. Ventilate if you can. So open a window, see if you have a good ventilation system. This isn't always possible. If you can, use an air purifier or HEPA filter. That's not always possible either. I completely understand that most people are not going to be able to refit their HVAC systems to include HEPA filtration in every case. So again, that's why these things are additive. Do as many of them as you can, reduce your risk as much as possible. Do things outdoors if you can. We already know that outdoors is not risk-free. Certainly if you're in a big crowd of people who are very close to each other outside, it doesn't really matter if you're outside. But if you're meeting up with 1 or 2 friends, if you have a picnic in the park and you're 6 feet apart and you are enjoying each other's company outside, that's probably okay. Especially if you wear a mask, especially if you're very conscious of that, and especially if you limit the time that you're spending with them. Wear a mask, obviously, and if it's possible, wear eye protection. That doesn't necessarily mean you have to wear a pair of nerdy chemistry class safety goggles. You could get a face shield, you could wear clear eyeglasses. Again, it's additive. So if you can do it, then that's wonderful. Do it with some of these other guidance measures. Physically distance, of course. 6 feet is not a magic number. Particles don't hit an invisible barrier when they hit 6 feet away from you. And again, in an enclosed space, they can build up. But physically distance if you can. It's one more measure that you can take to reduce your risk. Wash your hands. That goes without saying. As I mentioned, fomites are not thought to be the main mode of transmission, but they're still a potential mode of transmission. And washing your hands will also protect you from other viruses that are thought to be more dominated by droplet contact transmission, such as influenza. And then finally, disinfect shared high-touch surfaces. So you don't have to completely bleach your entire house or school or workplace, but maybe, you know, take a Clorox wipe and hit the doorknobs from time to time. Take care of those high-touch surfaces that a lot of people are touching. And if you do as many of these things as possible, you're going to reduce your risk as much as possible. So I don't like to prioritize any one measure, but if you can implement as many of these as possible in your daily lives, you're going to reduce your risk of exposure as much as possible as well. And with that, I'm gonna, oh yeah, one last thing. Japan people have been sort of mystified because Japan is a very populous country. It's very crowded. I've personally been to Japan and been on the subway during rush hour, and it is crowded. But Japan has not had the kind of surge in cases that other countries have had. And they have this policy that I think is just fantastic called avoid the 3 C's. So avoid closed spaces with poor ventilation, avoid crowded places with many people nearby, avoid close contact settings such as close range conversations. And they have a little pie chart down here, Venn diagram down here that shows that when you have all 3 of those things going on, you haven't avoided them, you're at the highest risk. But I think this is a really nice way to think about it. It's easy, it's catchy. And if you go to the Japanese Ministry of Health's website down here, they have a lot of fantastic resources. This is the English language website. Also come with great cartoons. So I say thank you to my colleagues in Japan for making this excellent public communications campaign. And then finally, questions. Here's my information if you want to get in touch with me afterwards. And now I will take your questions for the rest of our time together. Thanks for listening.
Thank you so much, Angie. That was a fantastic talk. I think that we all probably identify a little bit with Pigpen. We try really hard to stay away from the pig pens in our lives. But we do have a lot of questions from the audience. So I'm just gonna go ahead and get started. Our first question comes from one of our audience members, Karen Dell. And Karen, if you're there, would you like to ask your question? And if not, I will go ahead and ask it for you.
Sure. Hi. My question was, earlier on you were talking about the ACE2, I think it's ACE2 in the eye, and I just wondered if you could define what that is and remind us why it's important.
Of course, yeah, that's a great question, and I should have clarified that. So ACE2 is the receptor for the virus on our cells. It's normally a protein called angiotensin converting enzyme 2. That's what the 2's for. There are multiple enzymes called ACE. It's important normally for controlling blood pressure, but it's what the virus attaches to in order to enter a cell and infect it. So if there's no ACE2 on the surface of the cell, the virus can't get in. So any cell that is going to be infected with the virus has to be expressing ACE2 on its surface. Otherwise, the virus won't be able to infect it. So having ACE2 on the cornea of the eye, in those nasolacrimal passageways, means that those cells may be susceptible. And I say maybe because, well, they probably are, because we've infected animals through the ocular route, which suggests that if they're expressing ACE2 there, we probably are as well. However, we haven't looked at it really rigorously in people. And there are other host factors that the virus has to interact with in order to replicate. But it is likely, I mean, it can't infect a cell at all if there's no ACE2 on it. So if there's ACE2 there, that means that the cell could potentially be infected, and therefore it could potentially be a route of infection.
All right. Thank you, Angie. That was a very clear presentation once again. And now here is our second question from our guest, Royan. Royan, would you please unmute yourself and ask your question?
Can you hear me?
Yes.
Great. First of all, Dr. Rasmussen, thank you so much for an awesome talk. I forwarded the link for this to all my family and friends. So I think it's like really helpful to get it sort of straight from the horse's mouth. The question that I had was, what do we know about transmission and infection in children compared to in adults? I've been hearing things about this, and I would love to know that.
Yeah, that's a great question, and unfortunately one that we don't know a ton about. Like, so this is a really active area of research. What we do know for sure is that children can transmit this virus. They can become infected with it, and there's no reason why they can't spread it to other kids and to adults. And we know that there have been one super spreader event I didn't mention in the talk was at a Georgia sleepaway camp that was predominantly kids, and the people who were working there were predominantly teenagers and young adults who were the camp counselors. And the majority of people at this sleepaway camp became infected after there were just a couple probably initiating cases. So this was also a super spreader event. But the median age of the campers was 12. Some of the campers were as young as 6. So clearly there were hundreds of cases resulting in this camp environment of kids all living together in tents and, a camp type lodging that spread it very efficiently. Now, fortunately, what we also know about kids, but we don't understand very well, is that most kids don't develop very severe disease. This may be why some people think that kids are less susceptible, because we're just less likely to catch those cases. If the kids aren't getting very sick, they're not complaining about symptoms, their parents aren't noticing that they're sick, so they're probably being tested less and those cases are being identified less. And that's a relief for parents everywhere, I think, that if your kid does get sick, they're less likely to have a severe disease. They're less likely to have COVID-19 that lands them in the hospital, or worst case scenario, kills them. Now, there are some very rare, very scary multi-system inflammatory syndrome conditions that children have been reported to develop, but these cases are very rare. So in the vast majority of cases, kids don't get very sick at all. If they have symptoms, they're very mild. It's a cold-like infection. So that's overall good news. But the bad news is that kids don't seem to be any less susceptible. They're not immune to this virus. Kids should take the same precautions to avoid contracting it altogether as adults, just because kids usually don't live on their own either. They usually live with other adults, including adults who may be more vulnerable to developing severe disease. So the key take-home message is rest easy. Your kid's probably going to be okay if they do get COVID, but they can still get it. So the best thing to do is to prevent them from getting it in the first place by taking the same precautions that you would with a grown-up.
Thanks, Angie. Let's move on to a question from one of our audience members, Sarah Moorhead. Sarah, if you're there, you can unmute yourself and go ahead and ask.
Hi, Dr. Rasmussen. I really enjoyed your talk, and I've got the 3 C's memorized. I'm really excited about that. So my question is about shedding, and shedding with respect to a virus. How long do you shed after infection?
That's another great question. And this is something that I think has been really confusing, because there have been so many reports of people shedding virus or testing positive for months after they've recovered. I will say that there is a big difference in terms of, you know, what you should be doing if you're shedding infectious virus versus if you're shedding viral RNA or the genetic material in the virus. So we know that people are most infectious right before symptom onset or after symptom onset, or at the time of symptom onset, and then the virus, the shedding goes down. For people who are very sick, it may persist for a longer period of time. So people in the hospitals, that's why people caring for them these days are predominantly wearing N95 masks and other PPE to protect themselves, because people who get very sick can shed virus for longer. But people who are not very sick tend to stop shedding infectious virus after their symptoms have started to resolve. However, they may continue to test positive because, again, the RNA, the genetic material of the virus, the viral genome, is still present. And sometimes dead virus, essentially, can be detected by the test sometimes weeks to months even later after you've recovered. Those are very, very low levels of that RNA, and it doesn't mean you're infectious. And in fact, the South Korean CDC was so worried about this that they did a test, or they did 2 studies actually of almost 300 people who were so-called re-positive cases. They did an epidemiological study and found that they were associated with no new clusters of transmission, suggesting that they couldn't transmit the virus. They also attempted to culture the virus from all these people, and they were not able to culture any infectious virus, suggesting that they weren't actually shedding virus that could infect people, which is good news. But just because you're testing positive doesn't necessarily mean you're shedding virus. You might be just shedding RNA. I know that can be kind of a tricky concept, but the good news is that you're really the most infectious. No, I hope that's not my phone. I don't think it was. But you're most infectious right after you become symptomatic, or right before you become symptomatic. So the good news is you started to recover. You're probably not contagious anymore. You can go the period of time that your doctor recommends, and then go back to work and go resume your normal life.
That's interesting. So here's a question from Anne Sue about HEPA filters. So Anne would like to know if HEPA filters prevent coronavirus. And a related question is from another attendee whose question is, if I live in an apartment building, can I get COVID from the heating system in the apartment building?
So HEPA filters, yes, can remove particles containing the coronavirus from the air. They can They can remove or filter out virus particles themselves. Those by themselves probably don't remain infectious for very long in the air. They're actually not very stable. But certainly HEPA filters can help, but they don't help completely. So if you have a HEPA filter going in your room, but you're talking to somebody, you're right next to them, the particles that they're producing when they speak are going to be most concentrated right around them. So they may not actually get to the HEPA filter to be filtered out before they get to your nose. So that's something to keep in mind. HEPA filters can be useful. It certainly helps to purify the air, and they work, but they don't trump all the other risk reduction measures you could take, because if you're exposed to that air containing those particles before it makes it to the HEPA filter, you could still potentially be exposed. And sorry, what was the second question again, Sarada?
I don't.
Yeah. Oh,
Go
sorry.
ahead.
Yeah, go ahead. Go ahead, Janine. I was muted. I'm on.
No, yeah, it was just about being in an apartment building and,
Right.
heat in the ventilation.
Got it. Yeah, I got that. I don't know why I forgot that. It's been a long day, sorry. But yeah, probably not. You know, I never want to say for sure that's not a problem, but honestly, if this virus were being transmitted in that way through the HVAC system, through air ducts, through air handling equipment, we would see evidence of it. And so that office study, the call center in South Korea, was really strong evidence, in my opinion, and I think it's pretty accepted widely among epidemiologists, that this is not like measles, it's not like tuberculosis, where it can travel long distances through air handling systems. It only infected people in the same open office space in that call center. It did not infect people in other rooms on the same floor. And that strongly suggests that heating system, air handling equipment that may be unfiltered is not going to be a way that you can become exposed to it. It's really going to be those short range, close contact, same enclosed space, or what some people call shared air type exposures.
Great, thanks. I think that is probably good news and very comforting to many people.
Very good news.
Yeah, right. Let's move on to, there are a lot of questions about masks. People want to know, you know, if I have a thin cotton mask, a thick cotton mask, you know, a homemade mask versus an N95 mask, you know, how effective are all of these masks in preventing aerosol transmission? And I'm going to tack on another question, which I can remind you of after again, but why is it that we all hear that you know, masks prevent you from getting sick by me, but really, how is it that we're not prevented from getting sick by others by wearing masks?
That's a great question. Both of those are great questions. The thing to remember about masks is that no mask, not even an N95, is completely protective. So an N95, all that 95 means is that it filters out 95% of particles. Guess what? That means 5% can still get through. People can still be infected when they're wearing an N95 mask. So no mask is a foolproof magical shield that will completely eliminate risk. But the good news is that masks do significantly reduce the risk. And I'm going to get to your second question while answering the first. And the way that they do that, we think, is by source control. So when you are breathing out those particles, they're going to be most concentrated, and they're also going to be the largest as they're coming out of your mouth. The mask is right in front of your mouth. So even if it's a paper mask, even if it's a surgical mask, if it's a fabric mask that's a couple layers, a lot of those particles are going to get trapped in the mask itself, and they're going to stay there. And studies have been done that actually show that even though some of the particles get through, there are significant reductions in the amount of other infectious viruses that have been looked at this way. So rhinoviruses, influenza virus, masks can block those particles from getting through, and therefore they can block the virus from getting through. And that protects you. What we have less information about is what happens on the other side of the mask. So if you're wearing a surgical mask and somebody is unmasked in the same room, they're breathing out those particles. Those particles are subject to evaporation. So even if those particles are larger when they're coming out of your mouth, they're going to evaporate, especially if they're very small, quickly, and become something that's sometimes called droplet nuclei. Those are very small. They can stay suspended in the air for a long time. They're not as wet as the larger droplets that will be coming right out from the source. So they're floating around in the room. They might be too small for the mask to effectively stop. The other thing, though, is we really don't have much information on how protective masks are, even surgical masks or cloth masks. Certainly that can be very variable depending on what you're making them out of, how many layers they are, that sort of thing. We just don't have very much information about how protective those types of masks can be from the environment around you. So the reason why people say use them as source control, use them to protect other people from you, is that we just have more information about how well they do that. They may well offer some measure of protection against particles that are in the air. We just don't have, again, very much information about that. So we tend to focus on the way that we know that they work. But the point is that even if masks are not completely effective, which they're not, including N95 masks, they're still very, very useful. And that's why healthcare workers are using N95s all the time when they're doing aerosol generating procedures, especially. That's why people wear surgical masks. And in East Asia, people wear them all the time when they're sick or if they're in a place with lots of air pollution. There are many places where people have found mask wearing to be beneficial at the community level for a variety of reasons. So we should not rely on masks to protect us completely. We should just understand that they're one more piece in the risk reduction puzzle that we can implement in our own lives. The other thing I'd like to say is that N95s, we still have a shortage of those. And N95s are not as effective if you are not fit tested for them. So when I wear an N95 in the lab, it's because every year I have to go to my workplace health and safety and get fit tested to make sure that the N95 is conforming and fitting snugly to my face. There are several different sizes of N95s. So people in general should not put on an N95 if they haven't been fit tested for it and just assume that it's going to provide them with this healthcare worker level protection. If it doesn't fit you right, you might be better served by wearing a surgical mask or a fabric mask that is fitting to your face better. So that's something to keep in mind. And also keep in mind that if you are wearing a mask with a valve on it, that mask is not going to be protective as source control, because that valve is basically letting out a big stream of your respiratory particles. So don't wear masks with valves on them. Wear a surgical mask or a fabric mask. And if you've been fitted for an N95, then wear an N95 if you have one. But surgical masks and fabric masks should be just perfectly adequate for community level mask wearing, especially if you're implementing these other risk reduction measures.
That's interesting. So let me add on a quick question to that. What would your take be on reusing masks, especially surgical masks and cloth masks? How often should we be changing them or washing them?
So I'd suggest washing cloth masks more often, just because they're washable. But if you can't really wash them, you can certainly heat them up between uses, and that would certainly kill any virus. I mean, with a cloth reusable mask, after a while, your respiratory particles, viruses are not the only thing that can be in there. There's lots of bacteria in your mouth, fungal organisms, things like that. And eventually that will build up on the inside of the mask and become pretty gross, frankly. So it's not a bad idea to wash masks a lot. If you're wearing surgical masks, there are plenty of those. So you don't really need to reuse those. But since you're not using them, like you're not trying to be sterile, you're not in a sterile environment, it's probably okay to rewear them a couple times if you want to. I mean, I was on a plane yesterday and I wore an N95 mask again because I've been fitted for one. I'm probably going to rewear that mask because it seems fine. I'm not going to wear it to work. I have different masks at work, but I might wear it back out, on the plane ride back. if I need to. I think that right now, normally, ideally, I'd say never rewear any mask. If it's a cloth mask, wash it between every use, but that's not always possible. So if your mask is not intolerable for you to wear, and it's not broken, or it doesn't have holes in it, I think that it's probably okay to wear it. But this is a good opportunity for me to remind people that when you wear a mask, you want to make sure that it's covering your nose and it's covering your mouth. You don't want to wear it as like a headband. You don't want to wear it as a chin strap. And you don't want to wear it as a mouth cover only, because if you are doing that, then you really don't need to wear a mask at all. It's not offering any protective benefit if you wear it like that.
Indeed. Yes. Mouth and nose both covered. That's what a mask.
Exactly.
All right. Now switching gears, we have a very interesting question from Frank. Frank, would you like to ask your question, or would you like us to read out?
No, I'll ask the question. First of all, Dr. Rasmussen, thank you so much. I find these presentations very informative, including the question and answers. So thank you very much for taking the time. Like many seniors, I wear hearing aids. And what I've never heard was, I adjust them numerous times with my hands during the day. Now, I keep my hands away from my nose, I keep my hands away from my mouth, but with my ears, I do utilize my hands often. Does the virus at all, do we know, does it attack the ear canal at all?
I don't know. That's a great question, Frank. And I wish I knew the answer to that. I'm thinking probably not, only because there's not a lot of viruses that actually get in that way. The cerumen, the earwax, is actually a really effective barrier, and it's a more effective barrier than nasal mucus, which is itself a fairly effective barrier against getting exposed to viruses. But I have not, I mean, certainly you can get ear infections, you can get viral and bacterial ear infections, but I've never heard of a virus like this, a respiratory virus, gaining entry through the ear. I don't want to say it's impossible. I don't think anybody knows, to be perfectly honest. I think it's still a good idea, of course, to disinfect your hearing aids and maintain their cleanliness like you probably normally do. Certainly important to wash your hands. And I would recommend washing your hands. I wear contacts, for example, and I always wash my hands before I put in my contacts or take them out. It's just good practice in general to do that, to avoid bacterial infections as well. So I would say if you take those kind of precautions, you're probably okay, even if there is a small risk of getting exposed that way. I think it's much less likely that you would have virus float into your ear and you would get it that way. But I have not heard of that, Frank, and I'm going to ask some of my colleagues if they've ever heard of that, or if that's something that anybody's actually even looking at. I'd be very interested to know myself.
Thank you so much.
My pleasure.
I think that's a great question. I'd be interested to know the answer also.
Yeah, I really like doing these talks for the same reason that Frank likes it. I mean, that question was excellent, and it gives me something new to think about.
So we also have a question from audience member Lou Sheffer about the distribution of contaminated particles. Lou, are you there? You want to ask your question?
I'm here, if you can hear me.
Yep, go ahead.
Okay, all the advice you give seems very wishy-washy. Like you gave 8 things to do, but you couldn't tell which one is best. The CDC can't tell you whether dining inside is better than outside or by how much. Can't someone measure some of these things? Like you think for work, for example, if you had something that gave off aerosols and you put it where someone's working, then you could see where it went from the airflow. And maybe that would let you know whether the 6 feet is good enough or not. But I haven't seen any measurements of any sort about the aerosol contamination or distances.
Yeah, well, you're right that it is somewhat wishy-washy in the sense that it's really difficult to give a one-size-fits-all prescription for risk reduction because there's so many different variables. So I can say with certainty that indoor dining is less safe than outdoor dining. But I can't really put a number to it because so much of this depends on how many people are there. What is their ventilation system like? How many people are infected there? What are those people doing outside of the restaurant in their normal lives? It's surprising. These seem like simple things to address, and people have looked actually at how far different particles can travel under different conditions in the lab. They've looked at how long virus can remain infectious on certain surfaces. They've looked at experimentally generated aerosols and seen how long virus can persist in experimentally generated aerosol systems. They've looked at how much virus they've been able to culture out of hospital rooms that have COVID patients in them. They've looked at how long you can detect virus on surfaces in the real world. The problem with that is that it's really difficult to say under these experimental conditions or under these exact hospital conditions, that is going to be comparable to you going out to dinner at your local restaurant with people in your own community, because they're going to have their own air conditioning system, their own ventilation system. Your neighbors are all going to be doing different things. They're going to be talking about different things. They're going to be emitting different amounts of particles. There are just so many variables that it's really, really difficult to make hard, concrete, do this, stay this many feet away, don't say these words, don't sing this song, don't eat at this restaurant kind of advice. So that's why I think people are trying to give guidance that's very general. Now, the CDC has been problematic, to be perfectly blunt, in how they have been giving guidance to the public. And 2 weeks ago, there was a bit of a controversy because the CDC put up guidance that said inhalation is one of the primary modes of transmission. This should be guarded against more than surface disinfection and fomite transmission. Most scientists, myself included, agree with that statement. And then the CDC took it down without explanation. And then when asked about it, they finally said that, oh, it was a draft and we'll eventually put it back up. But that's very confusing to the public. And it certainly doesn't address your criticism that, yeah, this seems like it's very wishy-washy and nobody's going to be firm with you about what's more important than another thing. And some of it is just bad communication. There have been a lot of communication errors, including by the CDC and other public health officials. But some of it is that it's just really, really hard to give very direct, specific evidence or very direct, specific guidance because so many of these situations are different. I could tell everybody, install a new ventilation system, make sure you have MERV 13 or HEPA filters in there. But most, public schools are not going to be able to necessarily do a giant HVAC overhaul. So you have to try to balance, and I'm not saying that I'm perfect at this. I can always improve, and I will continue to take any feedback I get about how I can improve in this area. But it's really tough to strike a balance between giving specific actionable recommendations and making sure that it's still applicable to people's everyday lives. So I definitely hear what you're saying, and I wish I had a better answer for you than we don't know, and it depends. But that unfortunately is somewhat my answer.
All right, thanks.
Sure.
Thank you, Angie. Thanks, Lou. Angie, as always, we have a lot of questions, but I just want to make sure we are doing okay with time. Is it okay to ask a few more questions?
Yeah, I can take a couple more. I probably need to go at about 1:15.
Wonderful. All right. So the next question is from the audience. Let's see, Stefan Salfin. Stefan, could you unmute yourself and ask your question, please?
Oh, yeah, sure. Thank you. It's a long question. I try to make it fast. So the University of Illinois Urbana-Champaign has developed a program to test all staff and students at very high frequency, on average like 2 times per week, which has enabled them to live an almost normal life. Other highly privileged places, such as, for example, the White House, test everybody at an even higher frequency, which again enables an almost normal life, including ostensibly demonstrated ignorance of safety procedures that are required in the untested public. What frequency and pervasiveness of testing at what test speed do you think is necessary for the whole population to be able to forego socially inconvenient things like wearing masks and economically disrupting things like avoiding each other?
Yeah, that's a great question, because I would have to say that we would not have to be so, I guess, intense about making these recommendations to socially distance and do all these very inconvenient things if we had adequate testing capacity from the beginning. And that's going to vary from community to community. A community that has like a 25% positivity rate means that they're not testing enough. So they need to be testing more people and testing them more often. A community that has, you know, like here in New York City, up until recently, a lower than 1% positivity rate, not as frequently. But your point is well taken. One way to control this that's an alternative to doing some of these inconvenient things is to conduct adequate testing, adequate surveillance, so that you're able to find those cases early on before they know that they're sick, isolate them, contact trace who they've been around, quarantine and test them, and break those chains of transmission. Right now, we have too much community transmission across the whole country to actually realistically implement that, but including with the inadequate testing capacity that we still currently have. I think if we were able to implement some of these things like rapid at-home tests, where people could potentially test themselves, they're not as sensitive, but if they could find out like, hey, I just tested positive, that must mean I'm shedding bucket loads of virus. If you could test yourself every day with a nasal swab that you take yourself, almost like a pregnancy test, that would be a game changer, in my opinion. The question is, will these tests become available to the general public? And if so, will they be affordable, that people could use them to test themselves frequently? That might make up for some of this lack of testing capacity in the labs and in people's workplaces and schools and things like that. I think that that's going to be a huge question going forward. Just like with a pregnancy test, I mean, I don't know about other women who've taken pregnancy tests, but if you get a positive pregnancy test, you're not going to be like, oh, okay then, like whatever, I'll just go about my day. I mean, you're probably going to call your doctor and then like take actionable steps. I think the same would be true with do-it-yourself coronavirus tests. So I don't think we necessarily need to have an elaborate laboratory testing system. We don't need to depend exclusively on that. The question is, will we be able to get those types of daily rapid tests available to people so that we can dramatically increase testing frequency? So that's a great question. And I know that was kind of a non-specific answer, but the bottom line is more testing, more surveillance testing for sure. That would change things, I think, for all of us.
Thank you.
Thanks, Angie. We have a lot of questions about surfaces. Specifically, you know, is there a consensus on how long the virus lasts on particular surfaces? And do you feel like there's a need for sanitizing things like groceries and mail and packages? What are your thoughts on that?
Yeah, so we do actually have a fair amount of data on that. So people have done these studies in a laboratory setting, but it looks like the virus doesn't really persist on surfaces for more than a couple days and remain infectious. And even then, I should add, people are able to detect infectious virus, but that doesn't even necessarily mean there's enough virus there to cause an infection. So this is not a virus that's so infectious that if you get exposed to a single virus particle, you're going to get infected. You probably need to be exposed to hundreds to thousands of virus particles, which is why we're not seeing people who are shedding like tiny amounts of virus infecting people or being associated with these super spreader events. If this virus were more infectious, like measles, we'd be seeing a lot more cases of it because you wouldn't have to be exposed to this larger threshold of virus to become infected. So while we know that the virus can stick around on glass and plastic and steel for anywhere between 12 to 72 hours, under some conditions in the refrigerator, for example, it might be able to stick around for longer. That doesn't necessarily mean that huge amounts of virus are just waiting on your groceries, like waiting for you to touch them. And as far as quarantining mail or wiping down disinfecting groceries, I think that that's really unnecessary. I've never done that from the beginning of the pandemic. And to my knowledge, nobody's ever reported getting sick from handling packages or groceries or anything. Even if that is a risk, there's an easy way to mitigate that risk, and that is to wash your hands after you handle your groceries. Wash your hands before you cook food. There is no indication whatsoever that this virus can be transmitted by eating things. It's not a foodborne infection. So you don't need to worry about trying to bleach your produce or anything like that. And I think it's honestly just it's just a delay in which the time you can put your groceries away or read your mail if you're going to try to quarantine it. Just wash your hands after you're done handling it, and that should mitigate any risk, which is already probably pretty minor.
Interesting. Washing is the key, I guess.
Hand washing, yeah.
Washing. All right. Now switching gears again to asymptomatic spreaders. Here's a question about asymptomatic spread. So we all understand that asymptomatic individuals do shed virus. So here's a question that asks, do they always spread virus, or is there a period of time where they go between shedding and not shedding? I guess the question is, does the viral load change in these asymptomatic carriers?
Yeah, so that's a great question, and one that we don't actually know very much about. So truly asymptomatic cases where there are no clinical signs of disease from start to finish are pretty rare, or at least they're very difficult to detect. And it's really hard going through the literature and trying to figure out what's an asymptomatic case and what's a pre-symptomatic case, because often you see these studies where it's like, oh, 40–50% of people are asymptomatic. No, they were asymptomatic at the time of testing. Oftentimes they are not followed up with to see if they became symptomatic later. For patients that were hospitalized or at least were followed, that were part of a clinical study to look at this, we know that a lot of patients do develop at least some symptoms. So there probably aren't that many asymptomatic cases. And there was, on top of that, there was even another study in China that did look at asymptomatic cases where there were no outward clinical signs of disease and the patients never reported symptoms. They did CT scans on them and they found the same ground glass opacities in their lungs, which is a radiologic feature of COVID-19, that some severely ill patients had. Granted, they didn't have as much and they didn't report any respiratory symptoms, but there still were radiologic signs of disease. So then you get into a question of what's asymptomatic or not. The thing we do know is that there is definitely pre-symptomatic transmission. So transmission, when you are asymptomatic at the time, you may go on to develop symptoms. You probably will go on to develop at least some symptoms, but you're asymptomatic when you start becoming transmissible. And as I mentioned, and it was even, in one of my slides, I can just back up quickly here. This slide right here shows viral loads in terms of CT value, which is how the RNA is measured by the test, in days since symptom onset. And you can see here, it's all over the place because patients are very variable, but it steadily decreases. So virus goes down after the symptoms start. So it's unlikely that asymptomatic people are shedding tons and tons of virus compared to anybody else, or that they're shedding virus for a prolonged period of time. Most likely they're probably shedding less virus, which is probably why they're asymptomatic. But we really don't know that for sure. We haven't done enough studies of truly asymptomatic people to even really understand what the prevalence of asymptomatic disease is.
Interesting. So let me add one question here. So referring to pre-symptomatic, right? So if a person is pre-symptomatic and then turned symptomatic and tested positive, how far back do you go for contact tracing?
Boy, that's a great question. I think that most people look at the most secondary contacts right now. So asking who you've been around for the last, few days, and then hoping if you can follow up with all those people, then asking who they've been around for the past few days. The problem with contact tracing right now is that there's too much community transmission to do it effectively. There's not enough contact tracers, and there's too many cases. And then on top of that, there's been a real problem, and this gets back to the communication issue and confusion about what to do, and frankly, diminished trust with public health officials, is that people are not cooperating with contact tracers. They're sending them to voicemail, or they're just outright deliberately avoiding them. And so there have been major problems with contact tracing in general. So I assume that for that reason, at most, they're probably looking at secondary contacts, but I think it probably differs from state to state too, because contact tracing guidelines will differ depending on which health department and which public health officials are making those rules and deciding what's a contact tracing protocol and what's a case and what's not. So I think that's probably pretty variable, as with everything that I've talked about tonight.
Indeed, everything is variable. It's relative. So Angie, like I said, we would love to talk to you for as long as you're around, but I guess we should probably let you go now. So
I should probably eat dinner at some point.
Okay, you take care of yourself.
Yes. Angie, thank you so much for joining us again. This was a really informative lecture, just like last week, and we really appreciate your time. I want to again thank the audience for joining us and for asking such great questions. You know, it really made for a great seminar. And I hope that all of you, especially the ones who didn't get your questions answered, will come back and join us next week. We have our last seminar in this series on Wednesday, October 6th at 7 p.m., again given by Dr. Angela Rasmussen. And in that seminar, she will talk about ongoing efforts in developing treatments and vaccines for COVID-19. So please join us then. Thanks, everyone. Have a good night.
Thank you.
Thank you so much. See you next week.
Thanks, Angie.
Thanks.